Hello and welcome to your lecture on evidence-based practice, quality improvement, safety, and legal issues, part 1. Your learning outcomes for this lecture are that you will be able to describe the use of evidence-based practice to provide effective patient-centered care, that you will be able to differentiate between evidence-based practice and personal individual preference, that you will be able to discuss 4 elements of a well-formulated clinical question. Who is the focus of the question? What is being done to the client or patient or population? How does the intervention affect the client, patient, or population? And what could be done instead of the intervention? So evidence-based practice, we hear a lot about evidence-based practice now, but that hasn't always been the case. It started becoming more prevalent around the 1990s, but it's actually existed for much longer than that. Florence Nightingale, one of our nursing founders, even implemented evidence-based practice in the care that she gave her patients. But around the 1990s is when it really became the gold standard as far as physician care. Now, the Institute of Medicine has conducted several projects that have determined the usage and the usefulness of evidence-based medicine. There's a gap between what we know about the patient and what we do for the patient, and why is it that we do what we do. And in order to have the patients have the most beneficial treatment or the highest quality of care, we don't want to just do things because that's the way they've always been done. We want to do things because we know, based on the evidence, that this is a reputable, effective treatment or plan of care. And so that's why evidence-based practice is really significant and why we spend so much time talking about it. It's had a great impact on nursing practice. It has helped in the development of policies and procedures. It has helped change practice along the way. Some things that we used to do, we no longer do. One of those being, for instance, aspirating when you give an IM injection. That was something that was taught when I was in nursing school, but evidence has shown throughout the years that it's no longer needed. And so we still kind of find ourselves doing it, but really evidence shows that we don't necessarily need to. Another thing would be evidence showing, for instance, for a labor patient, that it is better for babies to go skin to skin with their mom right after delivery, that actually provides better thermoregulation than placing that infant in an isolate that's been pre-warmed. And so we look at evidence and we decide, first of all, is there enough evidence to change our practice? And what is the benefit of doing so? And when we decide that that benefit of changing the practice is in the best interest of the patient and is going to provide the optimal quality care that the patient deserves and needs, then that's when we're implementing that evidence-based practice. Evidence-based practice is a process. So you start by asking like a question. What is the clinical question that you have that you want to know? It could be something like, do patients who, and forgive my references to labor and delivery, it's just what I know, but do patients that have clear liquids during labor have a greater risk of injury than patients who are kept NPO? So you would start with a question, and then you would develop thoughts based on the best available evidence. So you would go and you would do your research and you would look at articles that studied this topic, and then you would appraise that evidence that you collected to determine whether or not the evidence was sufficient quality. So we're not going to just go to the latest magazine of Time and pull an article, or the latest parenting magazine and pull an article. We want to make sure that it's evidence that comes from a quality, reputable source. We're going to gather that information, and then we're going to put that information into play by applying it to the actual practice and determine what the outcomes are as a result. So when I was working as a lactation nurse, I did a lot of evidence-based study and practice on different things that would enhance breastfeeding or improve breastfeeding outcomes for moms that desired to do so. And so things just like, for instance, the skin-to-skin care, we actually implemented that for all babies because it benefited all babies, not just those who were going to be breastfed. But things like avoiding using a pacifier for the first 2 weeks of breastfeeding. Did that increase exclusive breastfeeding rates? Another thing was avoiding unnecessary formula supplementation during the first 6 months. What impact did that have? So you could take different things and apply the evidence-based process to them. I know a lot of times on the med-surg floors, they're looking at things like improving the outcomes for patients as far as reducing the number of skin breakdown or decreasing the length of time that a Foley catheter is left in. And those types of practices have been changed because of evidence that has indicated that we need to do things differently for the betterment of the patient. So evidence-based practice is comprised of 3 things. First, of course, the best research evidence that's available. Second, what the patient values. And then thirdly, the clinical expertise. And we as nurses demonstrate best practice by putting into play nursing actions that we have determined are based on evidence. We don't want to just do something again, and I know I keep saying it over and over again, but it's so important to understand that we can't just do something because it's a sacred cow, like the article mentions that I've linked for you all to read. We can't just do something because that's the way that it's always been done. We have to make sure that everything that we do in order to provide quality, safe care for our patients is founded in evidence. Now, even though we as nurses have a significant role in implementing evidence-based practice, it isn't always as straightforward as it seems. People do not like to change. People resist change. They're not comfortable with it. They want to do things the way they've always been done. And I really had to fight this battle myself when I was trying to implement changes in my role as a lactation nurse. And it can be really frustrating because sometimes it comes across that you are judgmental or that you aren't considering the whole picture when really you have the evidence to prove that this is in fact the best practice for the patient's safety or for the patient's quality of health. And so it requires the nurse in any situation to be able to handle conflict, to be able to, kind of stay steadfast to the evidence that they found, because people will resist that practice change. But the longer that you have those patients, the longer that the nurses are in that practice change, they will grow to accept it once they start seeing the results. So, keep hope that things will improve with time. Sometimes it will be the person that resists the most who ends up being your biggest supporter when you're trying to advocate for a practice change. Another example of an evidence-based practice change is how we treat muscle strain, for instance. Nurses in the past, we used to use ice for certain injuries for the first 24 hours and then use heat. But now recent evidence shows that just using heat is the most beneficial. And so that's why it's important too as a nurse that you're always staying on top of the latest evidence. You're keeping in touch with what current trends are, so that you can, notice when a change in practice needs to occur. When we're looking at current trends, again, we want to look at high quality sources of information, published research, expert opinion, institutional reports, and historical data. And in doing so, then we will determine what level of quality that evidence is. Another example of a practice change might include, for instance, alarm fatigue. This one report from the University of New Mexico, they talk about a facility that wanted to commit to eliminating alarm fatigue. We know that when we hear bells and whistles over and over and over again, sometimes the response time decreases. And so the staff developed protocols based on the research and the data that they collected as far as response times to adapt the protocols for the alarming system for that particular unit so that they could have a backup plan to guarantee that patients' alarms would be responded to in a timely manner. And so anytime you see an issue arise when you're in practice, don't think that you can't do something about it. Will it be hard? Yes. Will it require work? Yes. Will it require you kind of having to change the tide or push the envelope a little bit? Absolutely. But you could make a difference in the life of a patient. So the nurse not only has to be able to identify areas that they can collect data that is focused on the change that they want to see made, or that the change that has been made to determine its quality, but they have to be able to appraise that evidence. And so in this pyramid, you'll see at the top is level 1 and at the bottom is level 5. Level 1 is considered the highest quality. It's typically going to be like a systematic review or a randomized controlled trial, meaning that the participants that are in the study, it's been randomized whether or not they receive the control or whether they receive the treatment being studied. The risk for bias is very low, and it's just a very well designed, high quality research study. So it's a very high quality level of evidence versus level 5, which would be more of just based on an expert opinion or case-based reasoning, which would be the least or very low confidence that the evidence from that is actually reflecting the true effect. If you were to repeat that research, then it's very likely that the outcome may change. Whereas in level 1, it's very, very unlikely that the outcome would change. So that high evidence, that high quality in level 1 is a reflection of the most likely the reflection of the true effect, compared to lower down on the pyramid, which as you get lower, it's more likely again to be very low or very insufficient evidence that leads you to not really be able to make a firm conclusion about what actually might happen as a result of the intervention. Some useful websites when you are trying to understand or perform evidence-based practice are listed here. One of the initial steps in the evidence-based research process is to develop that question about what it is that you are looking to determine the research for. So again, I just want to remind you that evidence-based practice, whenever you're talking about evidence-based practice, you are talking about 3 factors that contribute to that practice. One being the clinical expertise, which is the clinician's experience, education, skills. The second component being the patient's values and preferences, which are just that patient, what that patient brings to the situation from their own personal experiences, what they have expectations about, what they value. Those are all under that patient values and preferences component. And then the third one is the best research evidence. And typically you're going to find that best research evidence when you look at those levels of evidence. The higher on the pyramid you go, the higher the quality, and the more reputable and the more likely that you are to be able to depend on those results. So again, in that evidence-based practice, you're going to start with a process. When you say, I'm gonna do evidence-based practice, the first step is to ask that question. Ask a question, whatever it is about, whatever you see that you feel like needs a practice change. You're going to determine what your question is, and you're going to formulate that question into what's called a PICO question. And in that PICO question, you have 4 different factors. You have the patient or the population, which is represented by the P. You have the intervention, which is represented by I, comparison, which is represented by C, and outcome, which is represented by O. So when is it appropriate to use a PICO question? Well, you're going to use that PICO question anytime you're looking for evidence to support best practice, or again, when you have a question about a certain practice in patient care. It helps you to form a focused question when you use this PICO format. It helps you as you try to retrieve results that are applicable to what it is you're looking for, so that you don't just get like 3 million results back from your data search, but you get a more appropriate and manageable amount of results. It helps you in brainstorming, and it saves you time. Sometimes you might see the PICO question not only as a PICO, but there may be a T at the end of it, which represents time frame. So again, in that PICO format, you're going to see P for population or patient, I for intervention, C for comparison, O for outcomes, and if there's a T, that's the time frame. So again, I'm going to be referencing the University of North Carolina at Chapel Hill. They have a research page that has some resources about evidence-based practice and formulating PICO questions, and I'm kind of going to talk through those with you all. And then there is that module that I linked to your lectures that will kind of help you navigate all this, because evidence-based practice is it's not necessarily the most interesting topic, and it can be a little bit difficult to digest, but we'll go over at the end of the lecture what I really expect for you all to grasp from learning about this. But let's talk again about that PICO. So that PICO, when we're looking, let's say we're working, and we have patients, according to this example that they give, patients who are chronic smokers, and they've been getting counseling from an RN, and they also get a self-help brochure about quitting smoking. But they don't receive any follow-up counseling after that. And so your colleagues, according to this scenario, are complaining. They feel like they're wasting their time because they think that the patients will start smoking again after they are discharged home. You are curious as to whether or not the counseling and the self-help brochure are really effective in helping patients quit smoking long term. So that's the scenario provided. And what you're going to do is you're going to formulate a question so that when you go and you're looking for research to support your hypothesis about whether or not you think that this is an effective intervention, that you will be able to yield the most useful results. And so in that P, the group of people that are of concern in this question, in the scenario that I just gave you, think for a second about who that P would be. That P should be the chronic smokers. You need to consider the most important characteristics of the patient or the problem, any kind of relevant demographic factors, what the setting is. That will all help you as you determine what that P is for that PICO question. And so this case, again, it's the chronic smokers. And then the I is the intervention. What is the main intervention, treatment, diagnostic test, procedure, or exposure? Also keeping in mind the dosage, frequency, duration, and mode of delivery if that's pertinent to the situation. So for this, we have the population of chronic smokers. The intervention is the counseling and self-help brochure that they're receiving. And then your comparison group, if that applies. In this situation, it would be the patients who aren't receiving that intervention. And then when you're looking at that comparison, it might not be just the lack of treatment, but it could be a different type of intervention. So you could say, well, one of these groups is getting the counseling and the self-help brochure, and the other group is getting a nicotine patch. So that could also be your C for comparison. And then your O is your outcome. Be specific, make sure to make it measurable. It could be objective or subjective. And so for this particular instance, they have formulated the PICO question as, among hospitalized chronic smokers, does a brief educational nursing intervention lead to a long-term smoking cessation when compared with no intervention? So again, that P for population would be hospitalized chronic smokers. The I would be the brief educational nursing intervention. The C would be compared with no intervention. And the O would be long-term smoking cessation. And again, you can go to the website guides, guides.lib.unc.edu/PICO/case, CASE. And that gives you that example of how to formulate a PICO question. You could do it with anything. Let's say we did it with, okay, my population. I want to know if students perform better on unit test when they get online instruction versus getting traditional classroom lectures. So my PICO question might be, the P, of course, the population is going to be students who receive online instruction, and I'm going to have that compared to students who receive traditional instruction. So do students who receive online instruction score higher on unit test than students who receive traditional classroom instruction? So that could be the formulation of that PICO question in that situation. Again, that's actually that's the same website I just told you. I forgot I linked it in here. But you can go to the above website and read over that case study to get a better understanding of how to formulate a PICO question. Before we move on into quality improvement, when you're looking at evidence-based practice, I really want y'all to understand the purpose of evidence-based practice, the nurse's role in evidence-based practice, how you can formulate a PICO question and what the different components of the PICO question represent, and how performing evidence-based research plays a significant role into improving the quality and safety of the care our patients receive. So next, we're going to talk about quality improvement. Your learning outcomes are that you can describe the role of the nurse in quality and process improvement, that you can relate benchmarking, sentinel events, investigation, and reporting and quality improvement process, that you can describe the use of the PDSA model, and that you can identify critical or never events as they relate to safety and quality improvement. The Institute of Medicine, if you've never been to their webpage, I would encourage you to do so. I'm going to pull up the exact address for you. Institute of Medicine, which is now called the National Academy of Medicine, can be found at https://nam.edu. This organization really focuses on quality in patient health care. There are also a couple of other organizations, one being QSEN, which is QSEN. QSEN is, and you can go to qsen.org to visit that website, and that is the Quality and Safety Education for Nurses website, and it's got some really great resources on that site as well. But the quality of care as defined by the Institute of Medicine is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So that all in a nutshell says that the degree to which those health services that our patients are receiving are consistent with current evidence, so that's where the evidence-based practice ties in. And not only are they consistent with that practice, but they help in having patients achieve the desired health outcome that we want for them. So we're improving the quality of care through the use of evidence. Again, the Institute of Medicine, now known as the National Academy of Medicine, as well as the American Association of Colleges for Nursing Essentials and the Quality and Safety Education for Nurses, are all significant factors and influential forces in quality improvement. So if you go to the QSEN homepage, you can see that they have several different options. They have resources, toolkits that you can look up, just different topics about like urinary incontinence, improving that in nursing homes. They have an article about understanding medication errors, involving a case of a urinary catheter implicated in a wrong route error. They have different resources. One most popular one is To Err is Human. That's from back in 1999, but it still plays a significant role in healthcare and in quality improvement to this day, because that whole premise of that article is not if we're going to make a mistake, it's when we're going to make a mistake, because we all are human and we know that we're going to make mistakes. So instead of punishing the person, we need to look at the process and look at how to improve that process so that there are fewer errors in the future. So it's a really awesome resource. I like to look at it sometimes to get ideas for activities for class as well, because they have some great resources for educators on here. When you think about a loved one who's been in the hospital, or maybe you've been in the hospital as a patient, and you think about what you want for quality care, take just a minute to think about what you consider to be quality care. Maybe not even quality care, but any kind of quality experience. If you say that you had a you went to a hotel and it was high quality, or you went to a restaurant to have dinner and it was high quality, think about what factors would determine that for you. For a patient to receive quality care, we want it to be safe, effective, patient-centered, timely, effective, and equitable. There's a video linked here that I would like for you to go view after, or you can take the time to do it right now, to look at quality of care, and what that means. I just noticed, I think that part of that address got left off for the YouTube video. So if you go to YouTube and look up quality improvement in healthcare, and then it's Doc Mike Evans is the channel that it's under, but it should have the address is right, except it should have an L after that Y. But anyway, it's a pretty good little video about it, so I thought you might enjoy that. So the nurse's role in quality improvement, we have to be aware of what the standards of care are, and we also have to be aware of what the outcome indicators are. And all employees have a role in quality improvement. I know when I served as a clinical leader, we had to do monthly quality improvement chart reviews. So we would do chart reviews to see, make sure that the nurses were identifying the patients prior to procedures, that there was time out performed. We would look to see if, like for the Foley catheter insertion, was there an order for the Foley to be inserted? How long did it stay in place? What was the indication? Were there any complications? So there was different reports that we would fill out on various processes, and we would gather all that data, and then quality improvement or risk management, the nurses in that department would review all of that. That way they could see if there was a trend in a problem, or if 3 months from now somebody came back with an issue, they could track backwards and see if there was a reason for that issue to have occurred. So Joint Commission, who determines whether hospitals are accredited or not, they want to see that hospitals are putting quality improvement practices into place. If you search for Joint Commission resources, you'll be able to pull up the Joint Commission website. And while you can access actual standards of care, apparently now you have to purchase them. I think at one time you could pull them up, but you can go to their website and you can see different parts of their website focus on, like, ambulatory health care, behavioral health care, the hospital setting. It gives resources as far as preparing for that accreditation process, as far as CMS and regulatory services, helping prepare for those visits. And when Joint Commission comes, everybody gets a little on edge, because it's kind of like when you're a grown-up and you know your parents are coming for dinner, and you want to make sure your house is clean and you cook the perfect meal because you want to make sure you're showing your best effort, right? And so that's why everybody gets a little on the edge. But Joint Commission and other agencies like Joint Commission, they exist to protect the public. They exist to make sure that hospitals are doing what needs to be done so that our patients have safe care, and that their care meets the expectations that any one of us would expect if we were in the hospital. So key factors in quality care, of course, we want to focus on the client. The patient should be at the center of the care that we provide. Teamwork and interprofessional collaboration, working with others, is a key factor, as is informatics, because we know the use of informatics allows us to track events, it helps us to see trends, helps us to keep a record of occurrences. Lifelong learning is essential, because things are always changing, and like I said, what is relevant and current knowledge now may change just in the next few years, and so you have to stay on top of that. So I'd encourage all of you to never stop learning. If it's going back to school to get an advanced degree, if it's just, getting a certification in your specialty area, whatever it might be, make sure that you continue to learn. And then the environment also plays a role in quality care. So there's a process, just like for evidence-based practice, there's a process for quality improvement, and that process is outlined in this slide. As a facility, you're going to have a committee come together, and they're going to develop and approve a standard of care. That standard of care, of course, is going to be based on the best evidence that has been conducted, whether it be through evidence-based research, or if they have policies and procedures from another institution that they're looking at, but it's going to be developed and approved, and it's going to meet standards of care. Those policies and procedures are then made available to staff. Staff get educated. So if there's a change in practice, you just don't roll that out and expect everybody to be able to jump on board and do it right away. You're going to have education provided to the staff to make sure that everybody is aware of the change in practice, make sure they feel comfortable with any changes that are occurring, and that they have an opportunity to ask questions. Quality improvement issues are identified by staff management or risk management, and the interdisciplinary team is then formed to review processes to improve the quality of care that's being given. So what's currently happening, that process is analyzed, data is collected, and then data is compared to what the benchmark expectations are. So for instance, if we expect that there's only 3% catheter-related infections after we implement this new protocol, but there's 6%, then we need to it's going to be a comparison done of what's occurring with both situations. How are we going to get from having a 6% infection rate to a 3% infection rate? And if benchmarks aren't met, then you're going to do what's called a root cause analysis. You're going to look at what's the root of the problem, what's causing this issue, and how can we fix it. We're going to come up with solutions and educate, re-educate, implement changes, and then reevaluate. Benchmarking is kind of like what you expect your limits to be, right? So if I set a benchmark, I want all of you all to make an A in this class. That's my benchmark, right? So benchmarking is the term that's used for standards set for acceptable performance. You can use benchmarks for outcomes, you can use them for different processes or structures that have been put into place. 3 generally accepted elements of quality focus on not only the outcome of a process, the process itself, and the structure for that process. So outcome standards focus on the results of the care that's been given. What are the outcomes? And we're going to set standards or benchmarks for those. Process standards, they focus on the actual process itself, not the outcome, but the actual doing of the process, that delivery of care. And then structure standards relate to the whole environment, the management environment, the organization, or the physical environment of that organization. So that's an important concept to take away, is that it doesn't always just look at the outcomes. It might look at the actual process itself, or the structure of the organization, or really all of it, to be really evaluating the quality of care. So we talked earlier about evidence-based research and evidence-based practice and how to determine quality levels of evidence. And now we're talking about quality itself. And when we want to change a process because of something being wrong, how are we going to fix it? So let's say, for instance, we notice that from 11 to 7, there's an increased fall rate on the med-surg floor. We need to do something about this to improve the quality of care. So we're going to do a PDSA, which is a Plan, Do, Study, Act. And that is a recommended model for improvement. You're planning what you're going to do to address the problem. Once you develop your plan, then you're actually going to do that plan. Then you're going to study the results of it and act on it to make a recommendation for a change. So before I move on to Sentinel events, I'll give you an example of a PDSA that I did when I was working as the lactation nurse. So we wanted to improve our overall exclusive breastfeeding rates, and we noticed that moms who had cesarean sections had a delay between the delivery of the baby and actually getting to spend time and have the baby to breastfeed because of the layout of the organization itself, where the operating room was located, where the birthing center is located, the dynamics of the operating room, all kinds of factors, right? So we planned how to address this. And we said, okay, let's take all of the equipment that we would need, which is not too terribly much, whatever we can have that we can leave in the recovery room, like the infant scale, maybe we can stop medications in the recovery room, medication cabinet, whatever details needed to be handled as far as that immediate newborn care that had to be done before that mom could transfer upstairs, we had that in place. And we had a trial period. So we planned what we were going to do to address the problem, and then we did it. And then we came back together as a group and we're like, you know what? This is what I noticed happening. So I noticed that, yes, it's great that we have these medications downstairs to give the baby, but the first hour they don't really need the medication because they're on mom's chest anyway. Or how about the recovery room nurse maybe had an alteration in the patient's vital signs because the mom's arm was kinked when she was trying to feed the baby and had the blood pressure taken at the same time. And so you talk about things that have arisen, things that have arisen and obstacles that were faced. So you've done your plan, you've done your do, you're doing your studying, and then you act on what you need to do to change that. And then sometimes it takes several cycles of a PDSA before you have your final result. Moving on for quality of care, I want to touch on something called sentinel events. So sentinel events are defined as an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. Not all errors can cause sentinel events, and not all sentinel events are the result of errors. And that's where things get a little sticky. A sentinel event is something you got to think about it being like this is serious business, this needs to be reported, this is not something that should happen on a day-to-day basis. This is out of the ordinary. And so when you think about sentinel events, again, you're thinking about things that are going to result in death, permanent harm, or severe temporary harm. An example, you go to have surgery and your surgery is supposed to be on your left leg. You're supposed to have an amputation of your left leg, and you come out of surgery and your right leg was amputated. That's a sentinel event. Another example would be maybe you had surgery and they left a needle driver in you or a sponge in you. Some foreign object was left, unintended retention of a foreign object in the patient after surgery. Perhaps right after surgery, the patient died unexpectedly. A newborn that dies unexpectedly, and I'm not talking about from complications. I'm saying the baby was born, everything seemed fine, and then all of a sudden you go in and the baby's dead before discharge. That is a sentinel event. Another example might be the suicide of a patient, the rape of a patient or a staff member. There are many examples, but you just focus on the fact that it causes death or physical, psychological injury or risk thereof. And there's a difference between a sentinel event and just what we consider a medical error. Medical errors would be the wrong medication was given, but it didn't result in any harm. Or you gave an expired medication, it didn't result in any harm. Those types of things would be more medical errors versus a sentinel event. And then a near miss are situations that that are where a negative outcome almost occurs. Like it's a near miss, like, whoop, we almost caused this patient to have an allergic reaction, but luckily we stopped it before it happened. So you still would report near misses so that the process itself can be looked at. And I know before I left the hospital, they were recognizing people for submitting reports on near misses. Like if, for instance, the wrong medication was almost hung, then the nurse would fill out a report. It would go to quality improvement. They would look at it and say, hey, good job. Thank you for letting us know. Now we can prevent this from potentially happening again. So it's not always, you don't always have to be worried about the punitive actions, because really we're focusing on processes and how to fix processes. Never events are considered sentinel events. They are no longer paid for. Preventable medical errors that occur are no longer paid for by CMS, which is Centers for Medicaid and Medicare Services. So again, sexual abuse assault on a patient within the grounds of the hospital, death or serious injury of a patient or staff member, say they went for an MRI, say for instance, like I have a pacemaker. Luckily mine, I think, is MRI approved. We're not going to test that out, but let's say it wasn't, and they knew I had that device, that defibrillator pacemaker in, and they still sent me for an MRI and I suffered injury, then CMS isn't going to pay the hospital because they made a mistake that shouldn't have been made. So that's just an example, as well as unintended, again, retention of a foreign object. But really, we are working towards a culture in the hospital and in other medical facilities of a just culture, a blame-free culture. We don't want people to be afraid to report errors, because we know, again, that we're human. We don't encourage errors and we don't want to make light of them, but we do recognize that we're human beings working with human beings, and things are going to happen, and we need to make sure that we have a blame-free culture, that we're positive in our work environment, that we all are committed to the same ideals of safety and quality, that we are transparent with one another, and that we use errors as a learning opportunity. I'll give you an example. Had a coworker who needed to give ephedrine because the patient had just underwent an epidural procedure. And during the epidural procedure, the patient's blood pressure bottomed out. And it was a common practice that we would, notify the provider. They would give us an order for ephedrine, and we had a nice little medication bag that we had pulled medications out, and we would give the ephedrine. Well, for whatever reason, this person had not had the medications already pulled, and so they went to the Pyxis to grab the ephedrine and ended up giving epinephrine. Now, fortunately, there was no significant harm done, but looking at that process, there were things that should have been done differently. Maybe the medications need to have a big bright sticker on them so that you can identify the ephedrine from the epinephrine. Maybe they need to be in a pre-made kit instead of us pulling the medications and putting them in a bag. So there are different processes that could prevent it from happening to somebody else. And along with quality and evidence-based practice comes informatics. We know that we rely on informatics to not only document our care that we give patients, but also to retrieve data, to communicate amongst different facilities. And in doing so, we have advantages and disadvantages that come along with it. Your learning outcomes are that you can describe the uses of electronic medical records and computer processes in the provision of patient-centered care, that you discuss advantages and disadvantages of computerized client documentation systems, that you explain the process for documenting client care in the event of computer downtime, that you utilize computer applications in practice to conduct an assessment, plan, implement, and evaluate care. We know that because of health information, we have been able to greatly improve patients' care and the quality of care that they receive, because we can communicate. You know, if you have a doctor at Wake Med and you have a doctor here in Roanoke Rapids and you have a doctor in Georgia, they can all communicate if they are on the same electronic medical system. And that allows you to have consistency in your care. You know that you're given that they're getting reliable information, and we know that it's easy to access it, right? Right now, the focus for health informatics is focused on admission systems that can capture demographic patient data and bed availability. So in the olden days, where you would call around and ask each floor if they had an open bed to place a patient, and that hasn't been that long ago actually, but now they're trying to implement systems that you can go and you can look and have a bed finder and see that there's an available spot for a patient. Of course, we're still focused on the electronic health record, as many of you who work at Vidant North may be experiencing the change from Meditech to Epic. And just, I remember when I was very fresh out of nursing school in the birthing center, we did chart in Meditech on our surgical patients that we had, but we paper charted on our labor patients and our newborn patients, and it was very labor intensive. I just remember my hand cramping by the end of the day because I like to document a lot, and in that area you document everything. Like if you take the baby out of the room, you document it. If you bring the baby back, you document it. You document if the mom's snoring. I mean, you document everything. And I remember the great pains that we would go to document. So fortunately, being able to document in a computerized system, it definitely helps cut back on time and helps to have consistent charting and just basically making sure that there's everything in the chart that needs to be there, but not too much extra that doesn't need to be there, because there is such a thing as overcharting. Barcode medication administration, how many times has that been a lifesaver in making sure that the patient got the right medication at the right time? And then there's also telehealth, and then radio frequency identification, personal health records, e-prescribing, those types of things. With informatics, one benefit is that you can receive diagnostic test results sooner. So whereas you used to have to wait to go to your doctor's appointment, now we have patient portals that allow you to retrieve your results very easily. Of course, that can be concerning if you have a negative result. So hopefully the provider is calling you with any negative results before you're able to access them yourself. Barcode medication administration systems have greatly reduced medication errors. I mean, it's easy to do. You grab the medication. It's just something as simple as you are supposed to hang an ampicillin 1 gram IV piggyback, but the pharmacy has also put the 2 gram loading dose in the same cabinet, and maybe you didn't need that 2 gram loading dose earlier because you had already pulled it from the Pyxis, and then you go to hang your 1 gram and you accidentally have the 2 gram in your hand, but the barcode caught it. So just, you know, you're going to get in a hurry from time to time, and that barcode medication administration system can cover you if you fail to do your medication rights like you're supposed to. But y'all wouldn't do that, I know. Decision support systems and CPOE, which is computerized provider order entry, has helped eliminate errors, because we all know that sometimes providers have messy handwriting and it can be difficult to determine what they actually want. And you can clarify that order, but consistency with CPOE order entry has provided a lot of relief when it comes to that. We also can easily manage electronic medical records and electronic health records, and there is a difference between an electronic medical record and an electronic health record. So the electronic medical record is that documentation of a single episode of care. You come in for the hospital for surgery and you have an inpatient stay that lasts 3 days. That is your medical record. You have you compile all of your visits for the past 2 years into one. That is your electronic health record. Or you have your record from this office, that office, and the hospital all in one electronic system. That is your health record. So longitudinal record of care. We can easily access, like I said, we can easily access patient information, which does have the downside of potential breaches of security, which we'll touch on. And you also have networking opportunities through listservs, blogs, and social media. Again, the electronic medical record is documentation of a single episode of care, whereas the electronic health record is a longitudinal record of care. We have point of care informatics, which is like your blood glucose using your glucometers, where it uploads the patient's reading automatically into a system after you take that blood sugar reading, is a great example of point of care. Computer-based alerts and reminders can also be provided by point of care technology to detect and prevent any potential adverse drug events, maybe if there's a drug-to-drug interaction or a patient has an abnormal lab value. And point of care provides access to patient data. For instance, with the blood glucose monitoring, you can pull up the patient's previous blood sugar readings and compare those right as it's in your hand. Computer-based reminder systems, we use those now. They're automated technology that can help patients as well as help team members. It encourages patients to adhere to their health regimen. It helps improve their attendance rates for their provider visits. It can help supplement discharge instructions and decrease readmission rates, as well as reduce clinic cost. You can get little pop-up boxes or text messages which let you know, hey, it's time to pick up your medication, or your visit's coming up. You need to make sure that you make arrangements to come see the doctor next week, those types of things. Clinical decision support is any kind of tool that provides clinicians, administrative staff, patients, caregivers, or other members of the healthcare team with information that is filtered or targeted to a specific person, which would help improve quality of care and reduce errors and adverse events, and improve efficiency. Along with informatics does come some ethical and some legal issues. Of course, we want to make sure that we protect our patients' privacy. Ethical decisions as far as to who actually owns the software, who actually owns that data, how are you going to preserve that information, what if there's a breach, what if there is a computer system crash, what if somebody uses that information fraudulently. Those are areas that might arise. So as nurses, we need to be familiar with applicable laws and regulations, various policies and procedures in the institution that we work in with regards to informatics. And we need to be sensitive to the fact of protecting patients' private information. You don't want to leave up the patient's record on the computer that's in the hallway when you step into the patient's room to help them to the bathroom. That could easily breach their confidentiality. You don't want to leave printouts of patients' confidential information on the countertop or put them in your bag and take them home because you need to do your paperwork on them. You know, you have to protect that patient's information like you would want yours protected. On social media, that has gotten many of people in trouble as far as sharing about their day at work. You may have heard about the story where some nurses took a picture of an emergency room after a trauma, and they had no malintent when they did it. They were just saying what a crazy, chaotic day they had had, but in doing so, they violated that patient's privacy. So you should never have any images of patients, of course, on any social network platform. You should not post any patient information, names included, of course, or anything in this small area that could give away that patient's information. You should definitely never make any kind of negative comments about patients or staff members. And it's difficult in a small area, but it's not encouraged that you have patient contact outside of the work setting. Now, I will say this is kind of a touchy situation, because let's say you form, like, okay, I have a patient who I helped deliver their baby. Well, after I've cared for them and we live in this small town, they may be on my news feed, right? But it's a very fine line, and you just have to be aware of being careful when it comes to that. You can't give out medical advice, and that was something that was very difficult for me when I was a lactation nurse, because I didn't want to come across like I didn't want to help people, but it's not professional, and it's not what's the word I'm looking for? It wouldn't have been prudent of me to advise patients on what to do to solve their breastfeeding issues via Facebook. But a lot of times people think that that's okay. And so I'd have to say, hey, look, I'm not doing you any kind of favor by trying to provide you with this information. I need to perform an assessment. You'll have to come in and see me, and then we can talk more. So it can be kind of sticky. And that concludes this lecture. There are a lot of resources that are referenced here, as well as I did put the North Carolina Board of Nursing and that UNC website that I verbalized during the lecture. If you want to go back and visit any of those resources, there is a part 2, so stay tuned for that.